Hi everyone, we're gonna get started now. Hi, I'm Muller. I'm the Vice President of Wisdom, and it is my pleasure to introduce our alumni keynotes for today. So we have Senan Ebrahim, who is the co-founder and chair of Hikma Health. Senan is a physician scientist and an entrepreneur dedicated to using technology to improve global health. He has an MD and PhD from Harvard in computational neuroscience and studied neuroscience at Harvard College. Senan is also the co-founder and CEO of Delphina, which is building a data platform for pregnancy care to improve health outcomes for moms and babies. Senan graduated from Harker in 2008. We also have Hassaan Ebrahim, who is the co-founder and CEO of Hikma Health. Hassaan works with public school districts across the country as a consultant with education resource strategies. Previously, Hassaan taught high school math through Teach for America in his hometown of San Jose, California. Hassaan has a master's in public policy from the Harvard Kennedy School and in neuroscience from the University of Southern California. Hassaan graduated from Harker in 2011. Everyone here is Senan and Hassaan. Thank you.
Hi everyone, good afternoon. Thank you so much, Marla, for the very kind introduction. It's such a pleasure to be back on campus sharing with you all our experiences at Hikma Health. I'm Senan Ebrahim, Harker 08. Such a pleasure to be back with my brother Hassaan.
Hey folks, I'm Hassaan Ebrahim, class of 2011. It's great to be back on campus. Good to see you all.
So today we're going to share with you our experiences founding Hikma Health. In 2017, when we founded this organization into the Syrian civil war, there were already 6 million refugees from that crisis. That number has since grown to 14 million refugees and internally displaced persons from the Syrian crisis alone. As Syrian Americans, this crisis deeply affected our family, and we were looking for ways that we could contribute. And being Harker alums and from Silicon Valley, technology being in our blood, we started looking towards ways we could create and deploy technologies to potentially educate folks in these communities to improve their health. So we entered the MIT Media Lab's Refugee Learning Accelerator, where we decided to build a chatbot that, through a gamified UI, would help educate refugee youth about hygiene, about type 1 diabetes, which is extremely prevalent in the Syrian refugee population, and empower them with Hikma, which is the Arabic word for healing wisdom. So while we stayed true to our mission, when we actually went to Jordan and met with refugee youth on the ground, we met with their parents, we met with their educators, we met with their physicians and their nurses, it became really clear to us that the need on the ground and the reality was somewhat different than what we had actually initially imagined. And our gamified UI chatbot, which we thought was so cool and so much fun to play with and learn from, unfortunately just wasn't helpful in that context. Because when we talked to the physicians, when we talked to the nurses and the pharmacists, the first thing that they asked us was, how am I supposed to even tell you who has type 1 diabetes who I should give this chatbot to? So we quickly learned that there was a need on the ground for us to be able to collect data as physicians and providers and be able to access that data in order to render care to these folks and then to actually educate them. Diving deeper with the folks that we were meeting with that you can see here in Jordan, it became very clear that whether you were practicing in a mobile van clinic, in an informal camp, whether you were practicing in the UN camp at Zaatari, or you were practicing in your own very busy clinic in Amman, you had the same problem over and over again with the lack of access to healthcare data. While I was in the camps, I heard the story of Hisham al-Abrash, which has since been published in the New York Times. Hisham was a 7-year-old Syrian refugee boy who had moved to Jordan, who had type 1 diabetes. Now, unbeknownst to himself, his parents, his care team, he kept having diabetic ketoacidotic episodes. So he kept presenting to the clinic at the camp with these sort of systemic flu-like symptoms. And every time he went in, the physicians who had only a couple minutes with him, they kept sort of dismissing him, saying, you're Russia, or you just kind of have flu symptoms, why don't you just go home and sleep it off? A few weeks later, Hisham turns up in a Jordanian hospital emergency room in fulminant diabetic ketoacidosis, which is a life-threatening emergency in type 1 diabetes. Thankfully, in his case, the Jordanian physicians were able to reverse it and bring him back. But it should never have been that close. and for thousands of kids like Hashem who are not so lucky. So Hashem al-Ebrash is one of the millions of refugees that was our motivation and our impetus to found Hikma Health.
So hearing Hashem's story, we knew that this was the problem that we wanted to figure out how to solve. How can we leverage technology, our resources being in America, to try to tackle this problem in some way? But we knew that to actually get there, we had to really refine and hone our understanding of the problem. And so as we talked to these clinicians and providers, we came to realize that healthcare delivery in these low-resource settings is fragmented, uncoordinated, and under-resourced. There's clinicians from all across the world serving on medical missions who come and serve. There are healthcare providers and local clinical organizations that need to coordinate with the local county and regional and ministerial departments of health. And all of these clinics and providers are incredibly overwhelmed by the numbers of patients that they're seeing and the demand for their services. And so all of these clinics and organizations needed ways to standardize and collect their data in order to actually improve the clinical outcomes that they were seeing with their patients. And so we knew that if we can figure out how to solve that, maybe there could actually be improvement, especially for conditions like Hashem's that are chronic illnesses. Chronic conditions like diabetes, hypertension, heart disease, all of these require an understanding of what's happening to the patient longitudinally in order to understand how to better treat and prescribe the patient going forward. So knowing that, we started to understand, well, why is there not a solution to this already? Electronic health records are technology that have existed in the States for decades. If you go to Kaiser, if you go to Palo Alto Medical Center, there is a doctor who has a computer and they capture all the information. They can tell you, what year you broke your leg or when you got your immunizations. And there was no such technology available in these settings. And it turned out that the reason that was the case was because existing electronic health records are just not designed for these low-resource settings. Electronic health records in the U.S. are primarily built for billing, so that insurers can know how much to charge your, so that clinicians can know how much to charge your insurer for and get all the money in the door. They're not really designed to understand clinical outcomes. They also are pretty time-intensive. If you talk to a clinician in the U.S., they'll tell you they spend a lot of their time entering data into Epic or whatever EHR they're using. And they're not designed for these really highly dynamic, limited time settings. In our focus groups and our communication with different providers, we heard that on average they're spending 5 minutes with each patient. 5 minutes total to do the initial consult and understand what's this patient's medical history, to do any examination, any diagnosis, and any treatment. All within 5 minutes. So any time that we're taking from that for the purpose of data collection needs to be really efficiently used. And then lastly, and sort of most importantly in this setting, we heard that in these settings, there is very limited access to consistent internet or network connectivity. It may exist at some places, so maybe in clinicians' homes they might have access to the internet, or every once in a while the network connectivity might be restored. But in general, network connectivity is not funny as the audio connectivity is put in too. But network connectivity is not a consistent thing that you can depend on in this setting. And so we knew that we needed to build a system that was offline capable and offline first in order to be able to really meet the need in this region. So as we sort of honed our understanding of the problem, we tried to think about what exactly needs to be a part of the solution. And we didn't want to come up with that on our own. We have never been providers on the ground in these settings. We don't know exactly what it is that clinicians need. And so we built upon a growing practice in technology and in public health around user-centered design, following innovators in the space like those at Medic Mobile, to really understand what is happening on the ground and what exact feature requirements would be needed, like by clinicians, in order to ensure that the product that we're building is really meeting their needs. And so we conducted field research. We sent teams on the ground. We were able to go ourselves, talking to a wide range of clinicians, administrative staff, nurses, community health workers, to really understand what exactly would the software need to require in order to meet their needs. We held focus groups, collected a lot of feedback on prototypes. You'll see some of these photos here are us demonstrating to different clinicians in Lebanon what exactly we built and getting their initial feedback from it. We'll see in that top picture, we were pretty taken aback at some of the clinic's attempts to try to collect data using paper records, detailed notebooks and a whole stacks and shelves of records, but many of them would never even open them once they documented it. They were never accessing those paper records again. So we knew that, from what we heard on the ground, we really tried to understand exactly what are the features that would be required in order to make this a success.
So having crystallized our understanding of what the need on the ground was, we decided to create a nonprofit organization, a tech nonprofit, Hikma Health, dedicated to creating free and open source technologies to empower refugee patients like Hashem, as well as their care teams, to actually deliver the kind of personalized care that they truly deserve as compared to what we had been observing routinely on the ground. So we incorporated as a 501c3 tech nonprofit, creating these systems and partnering with groups around the world to deploy them. We also went about building a team that could help us and support us on this ambitious mission. So what that meant was finding our friends who were software engineers from Google, from Amazon, from top tech companies. Fortunately, being from Harker, that wasn't too difficult. We found designers, we found physicians. I think half my class ended up being physicians, half ended up being technologists. So again, didn't have to reach too far outside the network for that. But we're very grateful for all of those folks, business professionals, designers, all coming in and supporting us, building this largely volunteer-based team at Hikma. So our approach is fairly unique. As you heard from Hassaan moments ago, the current EHRs that you might see in use that when you go to the clinic or the hospital here in the US, they just don't work in those settings. So how Hikma Health decided to approach this was to create a system that met the needs on the ground by being easily integrated, offline first, and easily customizable so that out of the box it will work for clinicians, but if they need certain modifications, we'll be able to meet them where they are. Welcome back, good to see you. And the key features that we identified that were the must-haves without which, clinicians taking care of folks like Hashem in these settings wouldn't even be able to do their job were first and foremost the offline functionality, right? Being able to store all of that data locally on their device while, let's say, driving around in a mobile band clinic in a mountainous region of Lebanon with low or no internet and cell connectivity. Support for multiple languages is essential, and what we mean by that is that even the care teams that were often providing care to refugees like Hashem were multilingual. Nursing staff and allied health professionals were typically Arabic language educated, Arabic language practicing, taking their notes in Arabic. The physicians were often flying in from Western nations and typically practicing in English. So the ability to immediately switch the user interface from Arabic to English became readily apparent, and we heard the same story from our partners in Latin America. So we supported Arabic, English, and Spanish early on with the native UX. The workflows also had to be simple out of the box so that we could support a practice environment where these clinicians are spending on average 5 minutes per patient, and they also had to be readily customizable. So as the needs adapted, and we'll explore this a little later in the talk with what happened when COVID hit, so that the clinicians could adapt their clinical workflow and their note-taking workflow in Hikma Health very quickly. A lot of the groups that we work with have their own data reporting requirements where internally they want to become more operationally efficient. They answer back to their own donors. So data reporting and generating these data reports in a rigorous and standardized fashion for them was also a key requirement. And finally, we have all of our data being fully encrypted up to HIPAA standards, which are the standards used in the United States for all patient health data. Even though we started out primarily international, we always wanted to provide the highest level of security for this data. And the motivation for that was, unfortunately, a lot of these folks, particularly from the Syrian refugee crisis, were highly vulnerable, often political refugees. So for example, a colleague of ours who practices in child psychology in Lebanon shared a story with us where, in that particular practice, they were storing records, all paper records, typically locking them in a locked file cabinet. And one night, someone accidentally left those papers out on their desk. The next morning, not only were the papers gone, but unfortunately the family to which those documents with sensitive information pertain had also been disappeared. So learning about these tragic losses in these communities and just how vulnerable these populations are, we put security front and center, even if it meant changing other features or changing our development cycle so that we can always ensure that their data is safely and securely stored. We are very proud of the Hikma Health system being designed to adapt to multiple geographies. So while we have built it primarily in partnership with folks serving Syrian refugees, and that was a cause that always has been and will always be dear to our hearts, we learned from folks in Latin America, in India, and other geographies just how important this system could be to their care delivery. Now that said, it is fairly specialized for 2 main use cases in the humanitarian setting. So firstly, in settings which are generally low resource, taking care of migrant folks in India, taking care of refugees in Lebanon, taking care of migrant folks and low-income folks in Nicaragua, for chronic care, for folks who have hypertension, who have diabetes, who have autoimmune disorders. These are all disease processes that require constant iteration and understanding over months, if not years. And Hikma Health is particularly well suited when folks are trying to take care of folks with chronic illness in these low resource settings. The second main use case is in an acute humanitarian setting. So with the ongoing tragic war in Ukraine, that's top of mind when something changes. With the COVID pandemic hitting in 2020, we'll talk a little bit more about that later. These are acute humanitarian settings where every minute counts, and being able to collect and access data in as close to real time as possible can be transformational for a clinical practice.
So with our product design and with a solution that we thought would really make an impact, we wanted to map out for ourselves before we launched into this work with partners, what exactly is our theory of change here? How do we believe that we're going to move the needle on outcomes for refugee patients? How are we going to improve the operational efficiency and function of clinics? How are we going to improve public health more broadly for these communities? And so there's three areas that we see Hikma Health really playing a role here. The first, I think, is on the most immediate interaction. Thinking about Hashems' interaction with his clinicians, where they sent him home, if they had had that data, they would have ideally been able to sort of diagnose him with type 1 diabetes earlier and prevent a future negative outcome. And so there's that individual level, the doctor-patient interaction, that having data is going to improve outcomes and improve their ability to provide personalized care. On the second level is the organizational one. So for organizations that we work with, like a mobile clinic in Lebanon or a primary care clinic in rural Nicaragua, how will access to data improve their ability to function as an organization? How will it help them allocate resources better, know how much medication to buy, how many clinicians they think might be staffed? That improve the general operational efficiency of their organization. And the third level, which I think is our aspirational one, is to really understand from a systems level, how can access to this type of standardized data improve organizations' ability to understand trends in public health in their regions? So how can the WHO and the UNHCR, how can they inform their decisions around large-level funding allocations based off of this data that we're seeing? And so with some of our initial conversations with different ministries of public health, we talked to some folks in Lebanon, in Senegal, trying to understand what would be useful for them, what types of standardized data do they care most about in terms of actually seeing. It's been pretty clear that there is a huge value add here. The challenge is that many different organizations are all trying to tackle this problem in silos, and if you're looking at global population data, you need that to be standardized in some way. The WHO has taken on this task on their own. Actually, it's funny, we were observing a clinic in Gaziantep in Turkey, and I see a nurse in the administrative waiting room take out this like big red notebook and sort of open it up and flip through, scan the room a little bit and write down a number. And so I go up and ask her what she's doing. She's like, oh, we have to report to the WHO every month how many patients we see. And this is how I do it. I just survey the room, guess how many people are here, and write it down. Because they don't have the time or the resources to make that in a more standardized way. And that's how that data from the WHO is how they make important decisions. So trying to change that at system level is something that we're very excited about contributing to in the future. So with our product and our theory of change, we knew that we wanted to actually get this into the field. We wanted to get this into the hands of clinical organizations or partners that could really benefit from it. But in doing so, we wanted to do it in a strategic way that set ourselves up for success. So we wanted to understand if we were going to pilot our solution, what needs to be true of the region or the clinic or the organization that we're working with to actually get it piloted. So the first was to understand, do we have strong support from the organization's leadership? Is there a director or the president or whoever runs this organization at high level and ultimately has decision-making power? Are they bought into this idea? Do they understand how structured digital data can transform what their organization does? The second was to understand if we had buy-in from the on-the-ground clinical staff who will actually be using the system. The doctor who's going to be having to sit there and use this app, are they excited about this? Do they have the bandwidth to do it? Do they have the resources to actually allocate the time for training? So do we have the support from the on-the-ground clinicians? Is there an administrative point of contact? Is there somebody who can actually help with navigating the logistics of what this implementation is going to look like? I think it's easy for us to sort of say, all right, people are bought in, they're going to do it, but who's the actual implementer on the ground? Who's going to help us carry this across the line in terms of implementation? The other one that we really thought about was we needed to find an organization that was working in relatively stable conditions. Now it's hard because the geographies and the regions that we are describing and care about are vulnerable and they are subject to a whole lot of economic, financial, social instability. and yet to try to work with an organization that even in that region still was able to carve out some stability was important to ensure that A, it was the right time for them to be focusing on a less than essential mission immediately. Like if they are, triaging thousands of patients constantly and don't have time to work with us to implement the system, maybe it's not the best fit. So we really tried to find, even within all this instability, let's find a region, let's find an organization that can dedicate the time and resources that are needed to actually see this pilot success. And then lastly, we wanted to actually find a place that would let us pressure test if our product actually works. So make sure that it's a place that needs an offline functional system because network connectivity is unstable. Or make sure that it's a place that has the type of demand and numbers of patients that can really test if our workflows are as intuitive and as easy to use as we think they are. So finding that type of organization was really important to us, and that's why we're really so happy to find this organization called Endless Medical Advantage. They're a mobile health clinic based in Bekaa in Lebanon, right on the border of Syria, serving approximately 15,000 refugee patients each year. They're an organization that was founded by Syrian clinicians, and they really serve as the frontline provider of care for many of the hundreds of thousands of refugees in that region. They're one of the few providers actually there on the ground. During COVID, they were one of the few organizations that continued to work. They were providing screening, COVID screening during the early days of the pandemic, and have really been an incredible provider and incredible partner for us. So in late 2019, we started working with them to build out a custom version of our platform, changing some features, creating a few new workflows, and then managing the deployment and getting it off the ground for them. So in early 2020, they started using our system and given us really incredible feedback, both positive and constructive in ways that we can improve, which Senan will touch on in a little bit. But it's been an incredible partnership, getting to work with them and see their clinicians on the ground using their app. Whenever, on their Instagram stories, they post photos and you see a clinician in the background holding a tablet or phone, like, it's great to see it in real life and actually out in the field. And one of their clinicians, Dr. Muhammad, shared that the program has allowed them to serve more patients and it's saved them a lot of time, which was the real thing that we were trying to do here. So from our first pilot in Lebanon, we wanted to sort of understand and test how the system could work in another geographic setting with an entirely different population of patients. And so the Nova Vida Clinic is based in Ciudad Sandino, a rural area in Nicaragua. They serve approximately 20,000 patients, mostly low-income workers, many of them rural farm workers in Nicaragua. And so their use case was a little bit different. Unlike EMA, that was a mobile van sort of constantly traveling around, they have a primary care clinic that's based in the city, and patients will come and sort of access treatment there. But in addition to that, they operate a number of remote care programs in the rural areas where they actually send out health promoters and clinical health workers to sort of treat patients in the field. And so they really needed a system that worked in both places, one that worked on the ground in the clinic that allowed them to capture and access all the data, but also that worked in this rural setting where there was pretty much no data or network connectivity. So that's why they were really excited about the Hikma Health offering, sort of trying to find a system to marry those two together. And so they've been incredible partners for us as well. They started using Hikma Health late last year, and one of their community health workers in here reported that the system has made their work a lot easier, and thankfully that there's patient information will be better backed up. They had some pretty bad flooding during the hurricanes, and so a lot of their paper records were destroyed, and so they're glad to have things that are digital now.
So through the deployments with Nueva Vida and Endless Medical Advantage, we got a lot of very helpful constructive feedback. Our whole goal with Hikma Health was for this to be a living product that we would continuously iterate and improve, and we took it through the first cycle ourselves. So from the feedback that we heard, first and foremost, our main goal with Hikma Health was to be efficient and effective for these clinicians to find the right patient and then to rapidly read and write data about them. We heard back from the field, particularly with our partners at Endless Medical, that they were having some trouble sometimes identifying the right patient. Now, this is a little bit of a particularity of the Arabic language, but you can transliterate names like Muhammad about 10, 15 different ways. And when these folks were typically actually using the system, the physicians were using the system in in English, they had to be searching with the right transliteration. So we implemented what's called a fuzzy search, which is basically a linguistic approach that enables us to find different spellings of the same Arabic name when it's written in English. So we implemented that, and we still heard that they were sometimes taking a little longer to filter and find the right Muhammad that they were looking for to enter records down. So we also added additional filters for phone number and camp number and other identifiers that could help them find the right patient. The second feedback that we got was that while we had this automatic offline syncing happening, there were sometimes the clinician or the user was unsure if the sync had taken place. So we implemented a feature that basically told them either, check mark, you did successfully sync, good job, or your sync was interrupted, alert, you should wait in the internet cafe and be able to retry that sync and make sure you get your data uploaded. They also reported that they found it challenging sometimes to go through this entire chronological core dump of all of the patient information that we had been storing for them. So a few months into the deployment with Endless Medical, we created this patient snapshot feature, which has been very well received by our colleagues that have been taking care of these patients for now months, almost years. And for them to be able to see essential information about the patient, which is screenshotted here for you. You can see visit history, medical history, chief complaint, exam results, and medications, which are basically the 5 things that every clinician wants to know in a minute before they go into the room to see the patient. All of that is snapshotted directly now for anyone using Hikma Health. And finally, clinicians were also reporting that the sync itself was taking a long time to upload all of that data that they had just collected out in the field a couple days later. And in diving into that, we realized that the photos that we were storing, which were largely just identifying photos of the clinician, this is not MRI or anything too complicated, but even those images themselves were just the heaviest items in terms of the size. So we decided, in conjunction with our usership, to create a version of Hikma Health that doesn't do any photo storage, so that we could basically enable rapid syncing, since that was really the priority, and the photos weren't adding too much for our users. When COVID-19 hit in March of 2020, I don't have to tell you all how much it changed all of our lives, looking out at all of your massive faces today. In these refugee camps, where the density, the population density that folks are living with is often up to 10 times as dense as New York City, for example, in the Rohingya refugee camps, for example, in Cox's Bazar and Bangladesh. These folks are living in that population density with poor access to care, with poor sanitation. You can imagine the kinds of COVID outbreaks that were taking place that our heroic partners at Endless Medical and elsewhere were actually trying to put out those fires. But as we thought about it and we engaged with them and listened to them about what they were seeing, what we realized is that they need a very rapid tool to be able to screen in basically real time as they're out in the camp who is at risk for COVID based on symptomatic presentation, recent travel, etc. So we implemented a tool based on guidelines from the US CDC, as well as the WHO and physicians that we worked with at Mass General and Johns Hopkins that had experience working in refugee communities, and we adapted it to a very rapid workflow that enabled clinicians to rapidly screen and identify the patients that needed to be isolated and or tested in order to prevent further spread. Now, at Hikma Health, I mentioned we previously had recruited a lot of our very talented folks from many different disciplines. We had a very large data science team as well at the ready. And when COVID broke out, what we were also hearing from a lot of community leaders that we started talking to, not just around the world, but here in the United States, which if you recall, in December of 2020, we were already the worst hit country with COVID. What we heard routinely from them is, what can I do? What can I do for my community to help stop that spread? Should I shut down the school? I'm sure many of you all at Harker have several months where you were not in class. And is that helpful? Is us not being in class actually helping stop the spread of the disease? Turns out not a lot of folks had actually studied these so-called non-pharmacologic interventions, which things like masking, we now know, are highly effective at stopping spread. But what we wanted to do, initially our data science team wanted to go and study, hey, let's look at the communities that have shut down schools. Let's look at places where workplaces are closed or public transport is closed. And it turned out there was no centralized data set where we could go and look at that at the local level to help inform community leaders from local communities like ours, as well as Native American populations, which were some of the worst hit during the COVID pandemic in the US. So we created a team of over 100 volunteers to basically crowdsource this data, to go and look within their own community and say, what is my public health department telling me we need to do in workplaces, in schools, and in transportation centers? And we created one of the largest local data sets of COVID-19 non-pharmacologic interventions or policies, which now covers over 1,500 counties in the United States, covering the majority of the US population, as well as 150 majority of Native American populations as well. And that data set has since been used by researchers at Stanford, Mass General, Columbia, and elsewhere to do both public health and econometric modeling to basically study what are the right policies to implement when to prevent the spread of disease. So we're very grateful to have made a contribution with our research team, this being a research symposium, in that way. Now, the next step of research for Hikma Health really looks at what is our system doing to help? What does adopting a free and open source, offline first, multilingual EHR actually do for the folks at MS Medical, for the folks at Nueva Vida? So in conducting that, we're using a framework called monitoring and evaluation, which is widely used in the global health field, which basically looks at two key things every time you would do any kind of global health intervention. First, for monitoring, you're basically continuously assessing. You have systems in place to look at, as I'm rolling out something like Hikma Health, what are the impacts it's having, both intended and unintended, on the population. And then finally, evaluation is when we take a step back. Let's say we spend 3 months with the system deployed, or we spend 6 months or a year, we step back and take a look at all of those outcomes and impacts. And this is really important. I want to share a case with you that is basically a lesson for all of us in global health about why we need to be conducting M&E studies, why a nonprofit like us is actually spending time and resources on assessing ourselves. So multi-drug resistant tuberculosis is a massive global health problem today. Tuberculosis was very effectively addressed throughout the last half of the 1900s in the United States and other developed nations, and these anti-tuberculous medications, these antibiotics, were basically delivered through an intervention called DOTS, which is directly observed treatment short course, and it was highly successful in Western nations where folks would report to a nursing station and be observed taking these medications. Now, when the World Bank and the UN and the WHO started trying to do global TB eradication in the 80s and 90s, they adopted DOTS and they said, hey, we're going to do this in Peru, we're going to do it in Argentina, we're going to do it in Azerbaijan. Did not work so well. Part of the reason being, in a limited resource setting, it was just difficult to continuously check in and see who was actually coming into the nursing station. So Dr. Jim Kim, colleague of the late great Dr. Paul Farmer, they wrote together in this assessment in 2005, actually looking into why did DOTS fail. And a huge part of it, they said, was we were not doing M&E properly, we were not doing it early enough, and then we actually unintentionally exacerbated the tuberculosis situation globally and now have MDR-TB, or multi-drug resistant tuberculosis, as a massive global health problem to contend with in all of the same countries where we were trying to eradicate it. So that was a very valuable lesson learned for us and others in the global health field. We're going in early. We decided to adopt M&E policies and to conduct the relevant studies to rigorously assess ourselves. So the studies that we're actually doing now, first, we have launched a study to observe the operational effectiveness of Hikma Health. So looking at outcomes ranging from the amount of time that a physician will spend on data-related tasks as opposed to patient care, the number of patients that a physician is able to see, which, as you heard from Dr. Muhammad from MS Medical, is an important metric to them, as well as how many patients are actually showing up to the prescribed follow-up appointments. Now, the real holy grail is going to be the second clinical study that we are going to launch later this year, where we're going to actually study the clinical outcomes and how using a system like Hikma Health actually helps our clinician partners drive those outcomes to improvement. And in the chronic disease space, we're thinking about things like hemoglobin A1C, which is a measure of diabetes progression. We're thinking about things like blood pressure measurements, which tell us how someone is doing with chronic hypertension, or things like tuberculosis. We're going to look at tuberculosis burden. So those are the clinical outcomes that in the second study we will be evaluating retrospectively and seeing how Hikma Health help our clinicians actually achieve better or worse outcomes clinically.
So we want to evaluate our impacts and make sure that we know what the outcomes that we're actually moving the needle on are, but we also want to try to scale our work. And so as we thought about what is our model for getting this tool that we believe can really make an impact, what's our model for really getting this out into the field, our initial sort of approach to this was us providing direct partner support. So working with organizations like MS Medical Advantage or Nueva Vida Clinic to understand what exactly do you need, how should we customize our sort of default application, how do we customize it to fit your exact need, and we'll manage all the deployment and software support for you in-house. Now that worked for MS Medical Advantage and Nueva Vida, but it is not that cost effective to have engineering time here in the United States dedicated to just managing and deploying these systems. It also really limits our ability to scale. Our engineering team has many volunteers, not a lot of time and capacity, and so our ability to scale to new organizations is pretty limited. And so as we think about growing that, well, we thought all of our software is free and open source. Everything is on our GitHub. You know, a clinic or an organization, we had a couple reach out to us, one in Pakistan, one in Uganda, saying, what you're doing is really interesting, we want to use your system. We said, great, here's all the information, here's some guidance and documentation, go for it. What we realized is that the types of clinics and organizations, you know, as we've said, electronic health records, they exist, these are out there. But ones that are designed for these types of low resource settings and clinics working in those low resource settings, there is limited technical capacity to actually do that work, to customize and fork the software and then deploy it. And so even though it exists free and open source, and we hope that clinics and organizations might be able to use it entirely independently, we realized that there was actually something missing there to generate and create the organizational capacity to do this customization work themselves. And so that's led us to where we are now, where we're trying to scale out these sponsored independent deployments. We provide a small tranche of funding and a whole lot of resources, office hours with our CTO, giving whatever context, whatever supports might be needed to build up that capacity at an organization in-house early on, and then sort of let them do the independent customization work, but with our guidance and support to get them out. So the benefit of this is that A, it's a more sustainable impact because organizations are not dependent on us, and B, it actually allows us to scale to countless more organizations. So in that sort of model of scaling, we launched this past year the Year of Migrant Health Initiative, which is an initiative that we're doing to try to scale to as many organizations as we can around the world. So we put out a call for applications for any clinical nonprofit organizations to apply to be a part of this program. We had a really great applicant pool and selected 8 different organizations in 8 different countries to provide this sort of hands-on support and training and overall guidance as a part of this program and being grantees of ours. And it also presents really great opportunities for us to do some of these clinical evaluation studies, to collect some initial pre-implementation data on how much time are you typically spending with patients, what are your baseline clinical outcomes, and then after 6 months or a year into this deployment with these grantees to be able to actually then collect another round of post-implementation data and do some comparisons. So these are our 8 grantees. We're really excited about it. It's just been like 3 months now of launching this initiative. They're all across the world. We try to think about regional diversity and ensuring that we're getting an opportunity to sort of test implementation in different contexts and different use cases. So we're really thrilled to have this operation off the ground, and this initiative comes from our many donors and supporters who allow us to happen.
Just want to share with you one specific grantee to highlight the kind of amazing work that our partner organizations here are doing. So the Refugee Health Alliance is a 501c3 nonprofit that was actually also founded relatively recently, around 2018. Very impressively, since then, they've come up to serve about 10,000 patients per year with medical services ranging from obstetrics, as you can see from this photo, to mental health, to primary care services, mostly in Tijuana, in Mexico, right across from the border from San Diego. And they have a very interesting clinical practice because they fully support these patients for whatever they need. And if they need some level of specialty care that's not available in Mexico, they actually bring them across the border into San Diego to get the appropriate care and services that they need. And when they contacted us as part of their application for Year of Migrant Health, what we found very compelling was that they were sometimes taking some of these folks, for example, a 12-year-old child with respiratory issues, they would bring him to one of the San Diego hospitals to be in the pediatric ICU, the intensive care unit. And the amount of depth of information that's needed to appropriately take care of someone in the intensive care unit is substantial. So they see Hikma Health as their way of being able to create a comprehensive data story around the patients that they take care of in Tijuana, and if needed, when they bring them to the United States, they'll be able to get these refugee patients the care they deserve. So we feel very fortunate to be partnering with them and supporting them as they deploy the Hikma Health system. We see the Year of Migrant Health as a transformational inflection point for Hikma Health. To date, we've been working with tens of thousands of patients, mostly directly supporting the work that is done on the ground to deploy the system. And as you heard from Hassaan, we are adopting this new model of change where we can transform practice for up to 100,000 patients by supporting them financially and enabling them to independently customize and then deploy the system in a way that works for them. From here, looking to the future, our goal is in the next year, by the end of 2023, to assess and then scale this approach that we're taking in Year of Migrant Health to ultimately serve over 1 million patients by the end of the year. And ultimately, looking at, unfortunately, the tragedy unfolding in Ukraine and the number of refugees worldwide growing from 80 million today to be forecasted to be over 200 million 20 years from now, the need for a system like Hikma Health is only going to grow. And we aim to do our part in supporting folks at a truly global scale, such that in 2024, we aim to support 5 million patients around the world. Now, our reflections we want to share with you today, as we hope there may be many other future social entrepreneurs out there in the Harker audience, students, and maybe also parents. And our goal is to share with you some learnings that, stepping back at 30,000 feet, what we've learned from this process. So for me, one of the main challenges was balancing the needs that I saw immediately on the ground when I first visited in 2017, 2018, with what we were continually hearing from different sites all around the world and how quickly that need changed and evolved during COVID. So balancing our understanding of a core need and the necessity of focusing that, and especially as a tech nonprofit creating a product, right? We have to meet a particular need with that product, but then being able to evolve to meet that perennially changing need. Striking that balance, we found particularly challenging as a tech nonprofit, and we believe every tech nonprofit will approach that differently. And for us, it meant deeply understanding that need, using that approach that Hassan shared of user-centered design, of really listening to the folks we serve to find that balance. We also do believe that the work that we've done, we've been very focused on the Syrian refugee crisis for the last 4 or 5 years. It's a cause that's very dear to us. But we've learned a lot from that we're now aiming to share with the world through our various research publications. And we believe that will help us and others potentially serve the refugees from other crises that are ongoing around the world, from Ethiopia to Ukraine. We also initially were very focused on making impact at scale, serving these millions of folks that we know need our help. And initially, we didn't fully understand and appreciate how important it is to just really absolutely perfect the product, to make it a quality product that's actually going to deliver substantial impact so that it's worth these organizations really engaging on, even if that meant going for a smaller population first to learn from. And now that we have completed that stage in our growth, we feel lucky that we're able to now serve at a wider scale. But initially, especially in the nonprofit world, it can be very tempting to go after the biggest impact possible without diving in and really learning. And I think we learned from our experience, and ultimately we're able to really dive in and learn for a few years, and now achieve the impact at scale. Another challenge I personally wrestled with was, as we built this team, there was so much response, so much love and energy and positivity around 2017, around the refugee crisis, the migrant crisis, and folks who wanted to come and participate, the designers and developers and the physicians and the business professionals that I mentioned. So there was a deluge of interest in folks who wanted to support as volunteers, support Hikma Health. And we ended up with this team of 40 plus volunteers that Hassaan and I were trying to manage. And it basically didn't really end up being optimal for the kind of product that was relatively focused, relatively specialized that we were aiming to build. So we ultimately actually ended up paring down the team, and now we have a very dedicated team of about 20, some of whom are paid, but most of whom are still volunteers. And these are the folks who are actually powering the work that we do and learning who the right folks are and to fit them to the needs of the organization. That's been a learning journey for us. And finally, we wanted to share a very positive reflection in this space where, particularly in the tech nonprofit world, we found a lot of alignment and a lot of partnership with other folks doing a very similar kind of initiative to us. So we mentioned Medic Mobile, now known as Medic, an organization that started out of Stanford about 10, 12 years ago, just 5 years before us. And they founded this organization to basically empower community health workers with SMS-based technology. And we're very successful, but had a lot of the same challenges that we are currently experiencing in our scaling phase. So we found them to be great friends and mentors and potential partners. And we would encourage you all the future social entrepreneurs out there, to engage with those that have done similar work before, because we learned a lot from them, and we're really grateful for their mentorship. And with that, we'd just like to give a nod to all of the folks that have made the work at Hikma Health possible. We're very fortunate to have had a lot of support from some of the Boston ecosystem. You heard Hassaan and I both spend a little bit of time there. And from the Harvard Business School entrepreneurship competitions to the MIT Sandbox and 100K competitions, we're very fortunate to get support from the Boston entrepreneurial ecosystem. This being Silicon Valley, we also were very fortunate to get support from a great tech nonprofit accelerator called Fast Forward, which I highly encourage anyone thinking about doing anything in the tech nonprofit space to learn from them. They supported us not just financially, but also with key mentorship and expertise. And I also want to give a shout out to all of our amazing private donors, especially the Harker families that have been so supportive with us along this journey. We also want to thank all of our amazing partners around the world and share with you a story that really motivates us in our work. And that's the story of Dr. Firas Al-Babban, our partner, who is the medical director of Endless Medical Advantage. Hassaan and I had the privilege of meeting him in the camps around the Baja Valley in 2019, and I had the privilege of shadowing him clinically in his practice where he was taking care of refugee patients, both in his clinic, in his mobile van clinic where he drove out to these camps, and when he would sit with these patients and their families in their own tents. And he told us this story, which is out of a man who was practicing medicine as the very last physician standing in his hometown at the border of Syria and Lebanon. The war hits, his town is basically destroyed. He and his family have to relocate to Lebanon themselves, being refugees. He joins forces with Endless Medical Advantage and recruits a whole cadre of Syrian physicians. And they start providing care informally themselves throughout the camps. They get funding and then eventually scale to provide this level of care to 10,000 refugee patients in their own community. So when we ever encounter any challenges ourselves at Hikma Health, we think about all that Dr. Firas himself endured, himself as a refugee with his own family, and his grit and resolve and dedication in rebuilding an amazing clinical practice for his community in Baja, Lebanon. And also, finally, just really like to thank the Harker community for really giving us our start, especially Ms. Chetty. We both did the Harker research programs and we were at these symposiums back in the day. And we're just really grateful to be part of this community and see all the good that you all are doing at this fair as well. So thank you all so much for having us. Happy to take any questions now. Thank you.
Thank you to both Senan and Hassaan for an amazing talk. It truly is inspiring to hear from Harker alumni creating real change in the world. Okay, so questions. Our first one is, certain hospitals and clinics have already implemented internet or maybe app-based medical documentation. So how would you say that Hikma Health is different from these?
I can start. Yeah, I think that's a really wonderful question, and one that we had to ask ourselves a lot as well as we were getting started. You know, when we began this journey in 2017, we did a deep dive trying to understand, are there any electronic health record systems or electronic medical record systems that would function in this space? Because we didn't want to re-engineer a wheel that was already working and functional if it was just a matter of connecting the dots. And what we found is that no EHRs at the time were designed to function with those bare bones characteristics that we had found, to be able to function offline, to have simple and intuitive workflows that, you know, can embed easily within an organization, and in general to prioritize clinical outcomes over other billing or reporting metrics that are required. And so at the time when we started, we really found this sort of unique niche, and I think in the last 3-4 years, a number of other incredible organizations have also emerged in this space to try to create similar products. And I think what we really are trying to do is to build networks and bridges. There's a wonderful group out of my alma mater, USC, Frontier Records, that is doing similar work, and we've tried to share best practices and learning. So there's a number of these organizations that are now burgeoning, but the existing legacy systems like Epic and these types of electronic health records that you find at a hospital in other parts of the world just aren't designed to function in these settings, so they're just not usable in the context that we're working.
Awesome, thank you. What would you say, in your opinion, has been the most challenging part of beginning and working on Hikma Health?
Yeah, so thank you for that question. And I think there have been so many challenges you heard and so many learnings, but if I had to highlight one, I'd say it's basically the rapid change that we've been seeing in this landscape and the rapid evolution of the needs. And that's not something I necessarily expected, and not something that, you know, a lot of the humanitarian world, all of these NGOs that we deeply respect, and, you know, since we were kids, we're looking up to like Doctors Without Borders, right? In general, most of these humanitarian organizations will figure out a formula and replicate it, right? They see some success and they replicate it. And for us, especially as the technical partner, building a product that needs to work in these environments, just seeing how quickly the landscape would shift. And, you know, we would hear one thing one day and then a month later, there's a new need based on, well, we ran out of gas and we can't do the mobile clinic anymore, so we're gonna bring people into the clinic. Or COVID hit and now we can't even do our core operations unless we screen people. Or we ran out of money and we're gonna shut down the clinic for a month, and when we have money again, we need to reopen it and know where everybody is. And those are the kinds of challenges that are, you know, you don't think about them when you're starting out, and when you're just in the thick of it, and you realize that that's actually what's most important to your patient and to your, to your partner who's providing care for them. To me, that was like a humbling experience to learn to listen, to basically say, well, I know that this feature is important, and that we need to put all that aside and listen to them. And if what's most important to them is helping them find money to run their mobile van clinic and buy gas so they can get back out there, that's what we're going to do for a month. And then they can get our system back online. So I'd say that was the number one learning for me, is like responding to this evolving need.
Okay, great. Last question here. What are your top tips for nonprofit outreach work, including promotion, organizing events, and getting support and funding from other organizations and companies?
I'll start on this here. I think a big part of doing this is storytelling, is knowing how to tell the work, how to tell the story of the work that you're doing. What exactly was the origin story? What motivated it? How do you think about the scale of your work and the actual impact? So I think knowing how to tell your story and how to communicate what it is you want to do, I think is key to then, when you actually communicate with partners, as well as Senan did talk about, I think using that time effectively and knowing how to target and hone your message to different audiences, I think is really important.
Yeah, I think Hassan nailed it. And basically, when you have that story, right, once you understand what it is that you're doing and why you're doing it, sharing it with the right folks at the right time. And I think that's the skill that's learned, but you all are fortunate to be in a community where there's no end of folks who are excited about technology-related and social impact-related organizations. And if you even have an idea, that's not too early of a place to start. I'll just share the story. We met one of our donors when I was sitting next to him on a plane, and just happened to be talking about the work I've done. It turns out he had actually funded a medic, one of our other kind of sister organizations in this space. So you never know who will be out there that will be supportive of what you're doing. And I'd say once you have the story down, share it. Share it with the world, share it online, share it when you're sitting next to someone on a plane, COVID permitting. And you never know. You never know who you will find out there, who, particularly with an issue like refugee and migrant. This is the country of immigrants, right? Especially in the Harker community, we see it all around us. And it's a beautiful thing, but there's also a lot of pain and a lot of these refugee stories that I've heard from folks whose families I've known for many years, that I was friends with in high school. And it only comes out when you share what our family has seen in Syria and what we're doing at Hikma Health for it, and building a community, a wider community around the mission. So I would say my advice to you all is it's never too early, it's never too soon. Once you have the story down, get out in the world and start sharing that story.
Awesome. Thank you so much again.
Thank you so much.